Thank you, Glenn. And good morning, everybody. Thanks for joining our session. We're really pleased to be able to spend this time with you. I know everyone is obviously incredibly busy through this period, more so than ever before. And I'd like to particularly thank Glenn and Sarah and Simon for taking the time out to participate fully in this as well. So thank you all. We're going to be running through, as Glenn said, some thoughts and reflections as to the important focus on community-based services in enabling us to continue to strive to improve outcomes for people, but also to help us manage and recover from COVID. So can I have the next slide, please? Just a bit of context for us as Newton, we work with public sector partners, so whether that's local authorities on adult social care, children's services, also NHS community providers and acute trusts. And we do that through taking a very evidence-led approach and really seeking to use that evidence and that insight to work collaboratively with those public sector partners to reimagine and redesign the way services are delivered, really striving to achieve better outcomes for people, do that in a way that also better engages staff groups, and also as a byproduct of that delivers some financial and sustainable financial benefit for the organisations. Next slide, please. So as I mentioned, we take an evidence-led approach, and that sees us first working with authorities to qualify what the opportunities are. I think everybody knows, the areas and themes of opportunity across adult social care, but really we want to take that evidence to another level and understand what is the scale of that opportunity, and then another level again in terms of what is it that's blocking that, us achieving that. How do I know what the key levers are that I need to drive consistently across the service and across the end-to-end pathway to deliver that those opportunities that we all know are there. And then once we've got those opportunities highlighted and that understanding highlighted, we move into a period of co-designing with practitioners. So working at the front line and as I said, sort of reimagining and redesigning the ways of working to see a step change in performance on outcomes. And when we're going through that process, it's important to continuously measure the effect of the change, continue to iterate it and improve it until we really understand what is the best step change we can make, but importantly, what are we doing to facilitate that step change? And then once we understand that, roll that out across the rest of the service in a way that is sustainable moving forward. Now, we've got 13 local authority partners at the moment, 2 of which are Royal Borough of Greenwich and Derbyshire County Council. It's a real privilege to work with all of our local authority clients and very much so with Greenwich and Derbyshire. And obviously, Derbyshire and Greenwich were really in the middle of that critical design phase when COVID broke. So if you click on to the next slide. Really, then the challenges were how do we refine and reflect the way of working to best support through this period. So it's really important for us to step up as a partner, to really step in lean into the clients to best support during this pandemic. And that saw us both flex the focus of our support, so changing scope and rediverting resources to vital areas where that support could be best placed, but also speeding up some of the implementation, such that some of those community-based services and the new ways of working were fully implemented to be able to deal with the peak of the crisis and the demand that was coming through. And it was important for us in our role to stay focused on those core principles of evidence-led decision-making, but also trying to foster the best environment around practitioners to support strengths-based decision-making and strengths-based practice. And lastly, to see our role as helping the authorities through the peak and then to slowly start to transition back into the new normal, where we could help manage the risks and identify the challenges and manage those challenges, and also make the most of some of the opportunities. And in all cases, we're seeing the risks, challenges and opportunities overlapping in a very complex environment. And I'm going to hand over now to Simon, who's going to run through the experience through this period from Derbyshire.
Okay, thanks Steve, and morning everybody. As Steve said, my name is Simon Stevens. I'm Service Director for Adult Care at Derbyshire County Council. For those of you that don't know Derbyshire, we're located just above the middle of the UK. We cover a geography of around 900 square miles and have a population of almost 800,000. And our county is made up of 8 districts and boroughs, a mixture of sparsely populated agricultural land and urban settlements. Around 75% of our population live in around 25% of our land area. And we have a higher than the national average number of older people in Derbyshire. In this session, I just wanted to share with you a little about the work we've been doing, supported by Newton, within our transformation programme, with a particular focus on using data to inform decision making, both within our Better Lives programme and obviously over recent months in our response to the coronavirus pandemic. So, faced with similar challenges to other local authorities around increasing demand and reducing resources, we knew some time back that we needed to refocus and reconfigure our offer to better manage demand and increase opportunities for people to maximise their independence. We were committed to delivering on those challenges through improving outcomes for people rather than being driven into service cuts. And we wanted to bring in an external partner to support us to do that, who had the same ethos as we had. And for us, obviously, Newton fitted that bill perfectly. And so back in January this year, having previously undertaken a piece of diagnostic work to identify opportunities, we began our Better Lives transformation journey. And then, obviously, just as we were beginning to get up to speed, we, alongside the rest of you, were faced with the challenge of the coronavirus pandemic. At the onset of the pandemic, we've got a number of immediate challenges that we've identified. So in our acute hospitals, it was taking us an average of 5 days to discharge someone into home-based support. We had a list of nearly 180 people waiting for home-based support to be sourced. The community pathway modelling from NHS England showed that we could need up to 250 short-term beds available for hospital discharge, and we'd only got 68 spread across that large geography. We have 2,200 directly employed staff working across 110 frontline care and support teams, and we were potentially expecting up to 700 of those to be away from work due to the virus at any one point in time, and obviously many others to be working from home. So deploying those resources was going to be a challenge. We also work with 74 private providers of home care and 224 residential care home providers, supporting thousands of residents across Derbyshire between them, who would also be facing those same challenges about staff deployment and absence. So, obviously, responding to those challenges would have been no mean feat at the best of times, but doing so during the course of a rapidly evolving national emergency required a huge amount of investment in time and resources, and similarly for everybody else. But the scale of the unknown quantity presented significant challenges to effective planning and really crystallised for us the need to use data to inform decision making. Next slide, please. And I think, like most others in Derbyshire, we were absolutely awash with management information, and our management information team were always struggling to keep up with demand for more and more reports from staff and from ourselves. And whilst we use those reports to support reflective analysis and to monitor performance, I think we recognise, having been faced with the challenge of the unknown and having to make decisions rapidly about resource deployment without being able to rely on experience or instinct, because this was all new, that we were less effective at using data to inform decision making in a sort of forward-looking approach. So recognising that, we began to utilise the 4 pillars to support our response to COVID. Next slide, please. So we began to more effectively use evidence to develop a forward-looking approach, as I say, and recognising we needed to make the best decisions possible to support both the people of Derbyshire and the wider system to respond to the pandemic. We developed models that predicted and tracked the flow of individuals across our services and showed us where our biggest pressures would be. So we brought together our local insight with data from Imperial College and NHS England and refreshed our modelling when those new data was released by those organisations. And that allowed us to consider and prepare for, for a range of scenarios and to adapt our service capacity to meet predicted demand. And through the sharing of our modelling into the local health system, we were also able to build on already positive partnerships we had with colleagues across the system, but also to develop a mutual confidence and make the appropriate preparations needed to support effective whole system responses to the challenge. Next slide, please. In order to keep up with the rapidly changing landscape and to ensure that our forward planning was informed by intelligence about the current picture, we also pulled together a comprehensive set of operational reporting that gave us daily live information about service activity, performance and capacity. And that gave us as a senior leadership team much greater clarity than we'd ever had previously with which to inform data-driven strategic decision making. And having benefited from that, we also recognised that in order to drive local ownership, build confidence and support local prioritisation, everybody throughout the organisation needed to have a shared view of that information. Due to the pace at which we had to work in response to the pandemic, we needed to be able to communicate new guidance, information or direction to locality managers and hundreds of frontline staff on a daily basis, and often at short notice, as well as have the right mechanisms to make sure that the challenges they were facing out on the front line were quickly escalated and resolved. So to achieve that, we developed a tiered system to ensure that any of those issues could be actioned by the appropriate level of management. And this, combined with the operational reporting, enabled us to support teams to focus on the issues that would have the greatest impact and allow for communication of the right priorities from senior leadership to the front line and back up again on a sort of 24-hour cycle. That two-way cascade and escalation structure is supported by communication material that summarise key messages from national and government evidence and guidance, as well as responding to the most frequently asked questions from frontline teams. And what we call the gold, silver and bronze meeting allow for face-to-face communication, obviously virtually in the circumstances, but also backed up by emails for those that were able to access it, and recognising that we have a large cohort of directly provided frontline care staff. We also utilise text messaging arrangements so that everybody across the whole organisation were getting up-to-date key messages during that important period. Next slide, please. So for us, we've sort of recognised that evidence-led decision-making isn't just about strategic leaders knowing what decisions to take and when, but it's also about following through to ensure that actions taken have had the desired impact. And that allows us to demonstrate when solutions work, understand why they don't, and iterate them until we have achieved the desired results. So, for example, from our modelling work, we knew that our acute hospitals would be under significant pressure to discharge patients quickly, and that our current reablement service wouldn't be able to meet that demand quickly enough. So we took a decision to simplify our discharge paperwork, to improve the visibility and capacity of social workers in our hospitals, so that we could make sure people were being consistently able to be discharged to the most ideal pathway. And that led to our discharge delays into short-term services reducing from around 5 days to around 1.5 across the county. To ensure we maximise the capacity of our reablement teams and to maintain flow out of hospital and ultimately home, we also created what we call the capacity team, which was assembled from volunteers across the council who weren't able to operate in their normal day job, And they were trained quickly to identify capacity in our short-term services so that we were confident we were maximising all of the resource that we had. When that team was launched in early April, we saw an immediate impact. So the average number of daily discharges into short-term services increased by around 50%, whilst the waiting list that we had operating for people waiting for home care reduced by around 77%. And the capacity of that service continues to increase and meet the demand as volumes in the hospital return back to near normal. But by taking those measures, we were able to ensure that timely access to home care for every person that needed it was available. And none of those actions are groundbreaking, but the difference for us has been that rather than relying on instinct and deferring to supporting rapid hospital discharge by using residential bed capacity, for example, which we knew was available, we have used the modelling to identify, excuse me, ahead of time that predicted demand for services and taken action to plan for sufficient appropriate capacity, as well as using that live data to flex our response according to the changing picture. And that's meant that we have really been able to support our colleagues to make the best use of our resources and support the people we serve to maintain their independence. I think without following this evidence-led approach, far fewer people would have had access in the short term that we would offer, which helps them regain skills and confidence to return home. Next slide, please. Next slide. Okay, I'm not sure. Yeah, thank you. So, first of all, although the need to focus our attentions into responding to COVID has been incredibly challenging, and obviously had some impact on the delivery of our transformation programme, it has also given us the opportunity to fully recognise the importance of really understanding the data and turning that into intelligence to inform decision making, evidence the need for change and to validate the delivery of outcomes. So I'd say that our stronger focus on an evidence-led approach has also really supported us to start a culture shift across all levels of our team and giving staff greater confidence in their decision making. Next slide, please. So, moving forward, we're absolutely committed to ensuring that the people we serve get the right support at the right time and in the right place to enable them to maintain their independence and live their best lives without relying on statutory services. And we believe that using evidence to inform decision making, maintaining the systems and processes we've put in place to respond to COVID, that we move those back into our transformation journey, will enable us to continue to drive that required culture change, continue to grow the confidence of staff through having clear evidence to back up decision making. It will reduce variation, it will improve outcomes for the people of Derbyshire, improve our performance and make better use of available resources, and ultimately provide the underpinning building blocks to embed self-leadership across Derbyshire. So that's me, and hopefully that was a helpful bit of information about how we've been managing the COVID response alongside you. So thank you very much for listening, and I'll hand you over to Sarah.
Thank you very much, Simon. And yes, so I'm Sarah McClinton. I'm the Director for Health and Adult Services in the Royal Borough of Greenwich. If we click on to the next slide, please. I think we've faced many very similar challenges to some of those that Simon has just described. Greenwich is a South London borough. You might be able to see from the map, we have the longest riverfront along the Thames. We have a population of about 280,000 people, and that's rising quite quickly. It's a very diverse London borough made up of people from very diverse backgrounds and huge inequalities. So not only health inequalities, but also significant inequalities in terms of some of those wider determinants of health. We go from a World Heritage Site, the Cutty Sark, landmarks that might be quite familiar to people, but also some very deprived areas. Over 31,000 people living in overcrowded conditions, and some of the most deprived super output areas. So real borough of contrasts. We have, as I say, a very diverse population, and we have, for example, a really startling statistic in terms of our Black and Black British community who start receiving social care services on average 14.4 years earlier than our white populations. So you can see just from that really stark differences. And in the context of COVID, where we've seen a very disproportionate impact on our BAME communities, as well as seeing Black Lives Matter and the highlighting of that structural racism, there's a real, real focus for us going forward in our work in terms of how do we understand and address that in terms of tackling some of those inequalities. So yes, we were working with Newton, and in March this year, I think we were in the reasonably early stages of the design phase, in fact, and we had three. So having had the diagnostic before Christmas, we had three main areas of work that we were looking at. The first was about embedding a strengths-based approach, so having a really clear focus on goals, on how we support people to live their lives, and very much a relational model, so building on links with local communities, but also working with our NHS partners and providers in that kind of relational way. The second area of focus was around achieving consistent practice and decision making, and then thirdly, there was some specific work around our learning disability population and how we rebalance some of that provision in order to support more independent living. So COVID hit. I think it's fair to say that it hit early and it hit hard in London. So in March we paused the programme. What we actually did was pause 2/3 of the programme, and we, similar to the way Simon's described, we had lots of support from Newton in terms of our response to COVID-19. So support for our bronze, silver and gold structures, lots of support around collecting and use of data, some of that capacity planning that we needed to do, help with some of those workforce challenges. So we did a massive restructure of our staff and how they were organised pretty much overnight. And we wanted to maintain a real focus on community and community services. So the part of the programme from the initial diagnostic, which we didn't pause, was the work that was specifically looking at reablement as a key enabler really for that strengths-based approach. And so I think as we were faced in March with this sort of huge surge that we were expecting, it was described as a tsunami that was coming our way. There was huge preoccupation in the system with beds, and did we have enough beds and capacity? And we felt it was really important if we were going to be able to respond to what we were facing, that we maintained that focus on reablement and community support. And what I'm going to do is talk through some of the detail of that particular work. So if we move to the next slide. So this just illustrates an example, really. So we have in Greenwich, we have an in-house reablement service. It's a huge asset. I think it's fair to say that it wasn't being used particularly well and wasn't as efficient as it might be. I actually joined Greenwich in November of last year, and I got a real clear sense quite early on that the criteria for reablement had kept changing. It was quite exclusive, and no one quite knew even what it was still doing. So people weren't referring to it in the way that they might have been. So Nancy is an example of someone who it was thought couldn't benefit from our reablement service. She didn't fit the criteria, And when Newton colleagues were doing the work, they came across her almost as an exception, almost as a mistake, really, that she'd managed to find her way to the service. So Nancy's an older woman who had been discharged from hospital. She came out of hospital following a fall with quite a significant support package, and her husband was looking after her at home. And I think it was her husband really that got in touch with us and pushed really for some more intensive support for her to become more independent. So she was then responded to, and we did work with her in an intensive way with the reablement service. And the outcome of that was that she wasn't fully independent, but she was then able to manage with a reduced level of support, and she was able to improve her quality of life, really, in terms of being more independent. So whereas previously the success criteria for the service had been the degree to which someone could be fully independent, what that had meant is that people like Nancy were actually being excluded. It was clear that we needed to really start from scratch almost in terms of rethinking the reablement service. So if we click onto the next slide. So as I said, the diagnostic happened before Christmas, and during that phase, colleagues looked through a number of cases, worked with practitioners, with multidisciplinary teams to understand what had happened to people and what alternative solutions we might have found if we'd looked at things from a different perspective. So I think that the pie chart, if you like, in the top right-hand corner shows that we found that 27% of all adults we reviewed could actually have had improved outcomes. So we wanted to give everybody the opportunity to live a more independent life, and that meant that we wanted to make sure that all residents could benefit from reablement, that we needed to increase, therefore, the capacity of our reablement service, and also make sure that it was as effective as possible, really, in terms of reducing the need for ongoing support. So if we move to the next slide, this begins to set out in some detail how we went about doing that. And the first thing that was really important was actually just being really clear about what was the purpose of the service and its culture and how was it going to operate in order to achieve the best possible outcomes for residents. So that included, during the COVID period, working in a very different way, for example, with our providers. So we not only deployed some of our day services staff to work within the reablement service, but also deployed some of our external home care staff to support the team and to encourage really that sharing and developing that kind of culture of a common purpose. So it was really important to work very closely with the staff, building their resilience and support. I think at times we were mostly between 50 and 60% of staff available, and staff were feeling quite vulnerable. They were the people that were going out into people's homes, not knowing people's COVID status. There was no testing at that stage, no PPE. So lots of anxieties as well, and things that needed to be addressed. But being really clear about that purpose and culture, I think, was really important. We also had in the middle of the pandemic, we just trained up one of our own staff who'd become one of the change leads. So she was embedded with the team, with the reablement service, and worked with colleagues to look at both people, practice, processes, and our systems. So purpose and culture was really important. And then Simon's talked a lot about the use of data, but that performance monitoring and having really clear visibility of the data was critical, really, in terms of moving us forward in understanding how people were progressing against their goals, but also having that real clear visibility. We needed to have really strong practice leadership. So, and there was very much a kind of multidisciplinary approach to setting and tracking and working towards those goals. So the reablement team wasn't working in isolation; it was working as part of that bigger system and supported by colleagues within the social work teams and with our health and therapy colleagues as well. Consistent ways of working then was really key as we improved processes. An example of that was a new scheduling system. So part of the inefficiency was rooted back to how our scheduling system didn't really work in the way that we needed it to. So I think it could only book full hours, for example, and some actual streamlining and improving those processes led to quite significant improvements in terms of efficiency. And then finally, as part of that, there were some digital tools that helped. So some of those digital tools that helped within the service, but I think also we've got a really exciting tool now that enables staff to see that person within the context of their community and some of the things that are around in their community, so that they're no longer seen in isolation. And we're able to make those links, really strong links with our communities, with some of the mutual aid that was mobilised during this period, and the links with our community hub, which was our response to some of the immediate needs in terms of food, medicines, etc., but was actually built on our kind of preventive approach to coaching and support for people in their communities. So if we click on to the next slide. So I think you can see from this slide a really big difference in terms of the outcomes and the results that we've seen. More residents are now benefiting from a service which is more effective and much more strengths-based, and as I say, much more linked into people's local communities and what some of the assets and resources are there. So through that data-driven approach to decision-making, people referred to reablement has risen significantly from 9.4 referrals to 17 referrals a week. And in the context of COVID and some of that capacity planning and anxiety really that was around in terms of how are we going to respond, you can see that being able to respond to that through much stronger reablement service was really critical for us. So some of those digital tools and process changes, etc., have also meant that we now have lower average duration of the service. So more people get the service, but it's a much slicker service and tighter in terms of that focused intervention, and then moving people on to longer term support if needed, or to other kinds of resources as is appropriate. And then thirdly, that bit about working as part of the system within those MDTs meant that we've also managed to make the service much more effective really in terms of reducing then the level of ongoing support that people might need. So you can see the figures there, but significant reduction there as well. So I was just going to say a little bit more about some of the broader benefits, because I think that so I think it's fair to say that our reablement service definitely needed attention, but I think that was obviously clear also to our NHS partners. And I think that actually some of the work that we did together with the CCG, but also with our community provider and some of our other NHS colleagues, was really important over that period. So we increased hugely the confidence of the system in reablement as an approach, and I think that's put us in a really strong position as we move into winter planning. And what does our home first kind of model look like? But that was really important in terms of increasing confidence in this service, but also that relational approach where we were working with partners and indeed with our providers as well, so that reablement is not working in isolation, but it's very much part of that system of relationships. I think the other thing I've touched on is it worked very closely then alongside our community hub, which, as I said, was built on, it was called Live Well Greenwich, but that was essentially a sort of preventive public health approach to coaching and support for people in their communities. And through the COVID experience, we mobilised an enormous amount of mutual aid, huge numbers of volunteers. So there was a real sense that actually we have these very rich and diverse communities and people really want to help, they want to do stuff. So reablement was no longer just a kind of service within the council, but it was also linked to all these broader community assets. I mean, clearly it's been a really challenging time for us. And I think I've touched on some of those issues around the frontline staff and how and the kind of fragility, if you like, of that group as the people that were going out having direct contact with people, certainly in the early days, without sufficient PPE and without some of the testing, which thankfully is in place. So we need to do an awful lot of work with that staff group to provide assurance and reassurance, and we've done a lot of work on kind of risk assessments and how we manage that, but also lots of face-to-face contact and training. I think the other thing is it was really important that we were focusing on reablement and an independence building approach. At the same time that some of our community rehab capacity was actually under quite significant threat. And all of our, many of our health therapists were being redeployed into ITU. So we were sort of, there was a real tension, I think, with where all of the focus in the system was going towards ITU, and we were really having to be very strong in trying to maintain this approach to building independence and supporting people in the community. And then I guess the other big challenge, which I don't think we've really cracked, I don't know if anyone has, is that our reablement service is predominantly focused on, not exclusively, but it's predominantly focused around people's physical needs. And actually, one of the huge challenges that we've got post-COVID is the impact on people's mental health. And how do we think about those independence building services that integrate more physical and mental health, and how do they really work effectively with people with learning disabilities and people with mental health needs in the more acute part of the system, as well as dealing with befriending and some of those more kind of common mental health issues, I guess. So I think that's a big question for us going forward. And then I'll just finish on the really I started with, that we have a massive challenge in terms of how do we address inequalities in our health system, but also more broadly. And we do think that independence building. Steve, but thank you.
Thank you, Sarah. Thank you, Simon. Really appreciate you telling your stories there, and obviously lots of great insight, hopefully, for people to take away. So we found over the last few weeks, it's felt like we've had sort of half a breath to reflect with our clients. We've also been running a series of adult social care roundtables, virtual roundtables with leaders from adult social care. I'm sure a number of you might have participated. We're going to be running some more through into the autumn and winter. So if you are interested, please get in touch. But it's been interesting to draw people together to gain that insight. And so it's been our clients, it's been the roundtables, it's been other contacts we've had across the sector. Excuse me. And I think one of the things that's come out quite strongly from people is what was true before is true now. You've heard that in the context of what Simon and Sarah have said, but obviously everything is more heightened in terms of the risks are more heightened, the challenges are more heightened, and the opportunities are more heightened. And as I mentioned before, the sort of interplay between those is an incredibly complex mix. And really that means that community services are vital to facilitating those independent outcomes for people. And we really wanted through this presentation, I know there's lots more we could discuss, but to draw out those two critical factors we've seen over the last few months in terms of setting up that right environment to help foster strength-based practice and strengths-based decision making. And you saw from the image that Sarah ran through, there's quite a lot to that. And I think importantly, the consistency within which that's applied. When we first go into our local authorities, we often see quite strong variation between teams and across different parts of the geography. So not only do we need to foster the right environment, we need to reduce the variation and then raise the bar more broadly as well. And then it's, as Simon highlighted, that evidence and intelligence running right the way throughout the service, not just having it at an executive level, but making sure it's available to the people that need it most in the timely fashion. It's forward-looking as well as backward. It's intelligence rather than just data, and intelligence that challenges perceptions rather than reinforcing perception. So I think, it's been an interesting period to reflect on it, and hopefully this has helped stimulate some thoughts with you all as well. So if we just click on to the next slide. I'd just like to thank you all for listening, and thank Sarah and Simon and Glenn again. And I think we're going to, if you can post any questions you might have via Slido, I think we've got 10 minutes left. So hopefully we'll be able to tackle 2 or 3 of those if we can. So I'll hand back over to Glenn.